What's up, my RT230s? Welcome to another exciting chapter. This is chapter 47, Patient-Ventilator Interaction. Now, if I sound funny, it's probably because I'm feeling under the weather. I'm congested. I do have a lozenge as we speak, so hopefully the lozenge soothes my throat. I think trying to talk very loudly and lecture has caused me to have a sore throat. So I'm going to do my best to get through this. This is only 21 slides, so it's not so much. And I believe your exam on this particular chapter is roughly around 22 questions. So that means I have 28 questions of ClinSim type of material to give to you guys. So don't think that the exam is just going to be 22 questions. It will be a full 50. I will add more to the mix. Okay, so let's delve right in. Chapter 47, Patient-Ventilator Interaction. This is out of your Egan's book. And so let us begin. Most of the time, we have patient-ventilator interaction that we program. So we put in the initial vent settings, and then we monitor the patient. Sometimes we put the settings incorrectly. As you will see later on in the chapter, it could be due to a flow issue or some type of trigger issue, or it could just possibly be something wrong with the patient. Well, anyway, when we do have a patient-ventilator asynchrony happening, sometimes you hear people talk about the patient fighting the vent or bucking the vent, which is B-U-C-K, bucking the vent. Now, we don't use that anymore because that implies that the patient is the one that is not syncing with the ventilator. But as time went on, we found out that the therapists have not been setting the ventilator correctly, thus causing the asynchrony or dyssynchrony, and it was not the patient. Now, if you think about it too, patient can't even really breathe on their own, so how can they be fighting the ventilator? Okay? Sometimes they're flow starved, and that's where we as therapists fail to provide flow to the patient that's adequate to create the tidal volume. And there's other ones too, as you'll see later on. Now, again, you have clinical technical issues that could cause poor patient-ventilator interactions. It could be physiological, or it could just be the ventilator itself. Okay. Controlled mechanical ventilation is entirely a result of the adjustments made by the managing clinician. So it's either the doctor or us, the pulmonologist or us, that could possibly cause the patient-ventilator dyssynchrony. This is during assisted patient-triggered ventilation or partial ventilator support, the patient and the ventilator must interact. That's why when we will look at how to put a patient on the ventilator, we do it with ideal body weight, because the ideal body weight actually deals with height, not their actual weight, because it doesn't matter how distended the girth is. It depends on how tall the patient is, because the taller the patient, the more volume that you can ventilate. Okay, so we're dealing with ideal body weight, but based on height. Okay, so when we put someone on the ventilator, we're considering how tall they are, and we're calculating a volume. All right, and so by doing that, that is our cookie cutter way of putting people on the ventilator. And then we also, once we decide, or once we've calculated the ideal body weight and we calculate the tidal volumes for this particular patient's height, then we normally go into our normal ranges or respiratory rate. And then when we normally start with FiO2, we start them off at 40% to 60%. So in between there. And then our PEEP, normally it's either 0, a +3, or a +5. Most of the time we do it +5 to mimic physiological PEEP. So that is our cookie cutter way of how we put people on the ventilator. So based on that, sometimes our calculations are off, or sometimes there might be a physiological, or there could be some type of biological reason why they are not syncing with the ventilator. Okay, so that's where you also have to look at your vent check sheet. You want to make sure if they're trending correctly or they're not trending correctly. Okay, also too, when you're doing your vent checks, that's another time to do a visual assessment. You want to make sure that the patient is not within or below their means to ventilate. Okay, so we want to make sure that the ventilatory demands are met. Okay, also too, that when we're there and doing the vent checks, we're able to adjust the settings if necessary. And then in red it says patient with high ventilatory demand need an inspiratory time of 0.6 to 0.9 seconds. That definitely means that we're going to inflate that lung really fast. It's not even 1 second. Okay, so we are going to have an inspiratory time shorter than a second. So that means we're going to increase the E time. Okay, we're going to increase the IE ratio. So therefore, they will have a longer expiratory phase, and that will help them breathe and meet their ventilatory demands. Now, they say ventilatory commands because we're trying to ventilate them. Okay, if we had low flow and that increased I time, decreased E time, they start auto-peeping, and they cannot breathe out the carbon dioxide, then they can't ventilate. So therefore, we are not meeting their ventilatory demands. So when we talk about patient-ventilator interaction, we're talking about patient comfort. We want them to have a decreased work of breathing. We want them to be comfortable. Synchrony during ventilator-assisted breaths. We want to make sure that they, meaning the patient and the ventilator, are breathing as one. A ventilator support should be initially adjusted to minimize the work of breathing and to allow the ventilator muscles to rest. That's very important. That's why when we first put a patient on mechanical ventilation, we want to make sure that they have a decreased work of breathing, and we want those respiratory muscles to relax. Now remember what I said before. If we don't let them relax, the muscles are going to continually expend a lot of CO2. So that is a byproduct of more of an aerobic respiration with increased work of breathing. I'm not sure if you studied that in biochemistry or in anatomy and physiology, but as your muscles start working more and more, you have oxygen coming in, then you have the breakdown and everything. Now then you have an output of carbon dioxide. Now, if we're trying to control CO2 levels, we do not want them to utilize more muscle, because that's going to increase CO2. Right? So if they're agitated, if they are having increased work of breathing, we really don't want that, because then it's going to be much more difficult for us to control that CO2. It also talks about diaphragmatic dysfunction. There could be something wrong with the diaphragm. It could either be a neurological issue, it could be a musculoskeletal issue. Who knows? We also have fatigue. They're just tired. All right. When you have someone in respiratory failure, muscles are fatigued. And if with lack of oxygen. Okay. Now think about this. If you have a patient with high CO2, they're in respiratory acidosis. Most likely, they are also going to be in hypoxemic respiratory failure. Remember, in class, I talked about them having both hypercapnic and hypoxemic respiratory failure. So they got the double whammy. All right. So if I'm actually producing more energy, right, and I have less oxygen, I'm not in an aerobic respiration. I'm in anaerobic respiration. So now I don't give off a byproduct of CO2. I give off a byproduct of lactic acid. Okay, lactic acid buildup. That's why when you guys work out at the gym the next day, you're so sore. That's the lactic acid. When you lift weights, a lot of times people will hold their breath. So that becomes an anaerobic respiration. Therefore, you're building up lactic acid. Now, this is going too far, but what I really want you to understand is that when patients work, and they work hard to breathe, they're building up a lot of unessential things that will cause them to be in an imbalanced state. Okay, and then also too, atrophy. If the muscles atrophy, they're not as strong, or you not have enough muscle to innervate when you have neurological stimulation. So these things can increase your work of breathing, and these things you definitely want to control, or should I say, you want to reduce so that the patient can have a decrease in work of breathing. Okay. Effects of poor interactions. Most of the time, poor interactions come out to be negative for the patient. Patient is suffering. So if you wanted to go to lunch, you wanted to go to breakfast, you got to get that last piece of toast. You got to get that last piece of fish, right? Or you have someone cooking something, you're like, wow, that's a lot of good grub, and you got to get there. So what do? And kind of just put the patient on whatever settings, and then you go take off. Well, guess what? You're hurting the patient because they're not interacting with the ventilator in a more harmonious or synchronous state. Most of the time, what causes poor patient ventilation interaction is hemodynamics, the length of mechanical ventilation, how long they've been on mechanical ventilation. Hemodynamics is just more of their cardiac output, blood pressure, all that stuff. Ventilatory pattern, how are they breathing? And last but not least, gas exchange. Are they exchanging really well? Are they not? Is it because of lack of flow? Is it because of a missed trigger, double trigger, things like that? That's going to adversely affect the patient. Most causes of poor patient ventilator interaction are of rather short duration. Now it can, and that's one of the dangers about it, is because it can happen over a short time, and then it'll just be done. So your ventilator might trigger an alarm, and then all of a sudden it'll just stop. So you hear the alarm, you get up, and all of a sudden it stops. And so now you're sitting here like, huh, okay. And you sit back down, you start charting, you hear it go off again. You stand up, and it stops. So most of the time, you want to have a habit of looking at, if you're able to, and if your ventilator does it, looking back at the alarm log and seeing when the alarm triggered. Most of the time, you can kind of trend and see, okay, well, around this time it's been happening, and you can even see how long has it been happening, and what is the frequency. If it's alarming every 5 minutes for the past 3 days, that's something to look into. Okay, now I don't want you to think, well, that's a director's job. You are still part of the data collection process in the department. So when you collect data, your manager or your director can have an easier time determining what to do. Okay. Most causes of poor ventilator interaction are of rather short. Okay, I said that. Sorry. Tension, pneumothorax, bronchospasms, and edema. Those are, they might trigger a poor patient ventilator interaction in a short duration, but it's going to alarm after a while, because tension, pneumo. Air starts pushing into the lungs, and you have that tracheal deviation. And then with the tension pneumo, just remember that your mediastinum and your trachea shift away from the side of the pneumothorax. So if I have a pneumo on the right, my mediastinum and my trachea are shifting to the left because all that pressure is coming from the right side. All right, so I want you to remember that because that's on the exam. And then it says asynchrony is more subtle. I had said it before. Sometimes you stand up, you're going to go answer the alarm, and it stops. All right. And it says it is difficult to identify that can persist for the length of time. So, yeah, the length of time may not be as long. And on that note, too, it's short-lived, and you can just dismiss it. You might think patient was probably moved by the nurses, patient was coughing a bit and stopped, anything, and you're thinking, okay, nothing's wrong, when in actuality they're causing a asynchronous or dysynchronous event. So asynchrony has been associated with, again, we talked about increased length of mechanical ventilation. After a while, maybe the patient's feeling better, they might want to breathe on their own, but you got them on AC. And so they might start having a patient ventilator asynchronous event, and therefore you would have to deal with it. Now, here's the thing. If you have a patient on AC and they are breathing over what you set the respiratory rate, so if you set it at 12 and they're breathing 24, they're going to be fighting the vent. There's going to be a lot of patient ventilator asynchrony. So in that particular instance, you're going to shift them to SIMV. Okay, let me say that again. When you have a patient who's on AC mode and they are breathing more than the set respiratory rate, meaning to say if you set it at 12 and they're breathing 24, 26, that means they're breathing 12 extra breaths, 13 extra breaths on their own. They got a good pull, they're able to trigger, and they're most likely able to get volumes. Once you see that, don't be afraid to switch them to SIMV, because if you don't, they're going to have an increased work of breathing because they might want to breathe, but the ventilator is not letting them breathe. Or if they're pulling volumes, let's say in their own triggered breath, they pull 420, but on AC you program 550, they're going to get that 550. So right there, that's going to cause possible overdistension, because if they're pulling 420 and that's what they are normally pulling, and you're giving them 550, that might cause some overdistension. That's going to cause some asynchrony there. So in that situation, you want to switch them to SIMV to allow them to breathe on their own. And depending on how much their volumes are, if they're pulling 450, 480, and you put 500, don't even add pressure support. But if they're pulling 200, 220, and you had them at 500, and you see that their minute ventilation dips when they trigger their own breath, yeah, go ahead and put some pressure support. It won't hurt. Okay, increased ICU and hospital length of stay. And that's just the thing. Remember, we programmed it and we caused it, and we're not identifying it. So therefore, patients' ventilatory needs are not being met. So every time we do a blood gas, that PaCO2 is still going to be high. And so we're going to wonder what's going on, but then the doctor's just going to sit there and say, okay, well, let's just keep the patient for one more day. So we'll continuously monitor the patient, which will increase their length of stay. Now, I don't know if I told you this, but remember, every diagnosis has a certain length of stay. For example, if I have a diagnosis of pneumonia, my length of stay based on my diagnosis is roughly around 5 to 7 days. After that, I got to get out. Why? Because the insurance company will not pay past 7 days. So if you, as the respiratory therapist, cause the asynchrony so the patient has to increase their length of stay, Your boss ain't gonna like it. The hospital's not gonna like it, because once they do an investigation, they found out that you set the ventilator wrong. Yeah, they're going to be yelling at you because you caused the money. Because if you have to extend the length of stay for another 2-3 days, the hospital has to pick up the bill, not the insurance company. So again, you got to also understand, amongst all this stuff you're learning, all this knowledge, you're working for a company, which is called a hospital. So this is important in the hospital sense, because then that's going to cost them money. Now, if you cost the hospital money, guess what? You're not going to get a raise. Okay? All right. An increased need for tracheostomy. Okay, so here's what we've done. We intubated the patient. Normally, we keep the patient intubated for 14 days. Okay? That is how long we keep them intubated. After that, we got to trach them. Now, if you cause the asynchrony to increase the length of stay at the ICU, and then all of a sudden we're on our 14th day and we can't get the patient off the ventilator, then we're going to have to trach them. Okay, that's just how it goes. Either we extubate or we trach. And how much more horrible it would be if you as a therapist caused the asynchrony, which increased the length of stay, which cost the hospital a lot of money, and now you gave this patient a tracheostomy. Not you per se, but your actions or your lack of knowledge has led to an innocent patient who should have been off the ventilator a long time ago, but still intubated and vented because you caused this asynchrony, and now they have to get a tracheostomy. Shame on you. Okay, and then again, increase in ICU and hospital mortality. If we're not meeting the ventilatory demand of the patient, that CO2 is not going down. That's going to wreak havoc on the body, and the higher the CO2 is, or the more time that the CO2 stays within the body, the more toxic it is to the patient and may possibly cause the patient to pass away. Now, patient ventilator assessment. You have to look at the ventilator settings as well as know how to make those adjustments to minimize level of asynchrony. So that's going to be you guys, and this is what we're going to be talking about further on down the chapter. Excuse me. All right. So most likely, our patient ventilator interactions results in a sudden respiratory distress. Notice the word sudden. It's not like a nice and easy trend you'll see. It's sharp. The trend's going to turn downward, and it's going to turn downward fast. So they're going to go into respiratory distress. Now, it's going to be due to an abnormal respiratory drive, which is a patient-related cause. And the thing is that it's us not ventilating the patient well that's causing the abnormal respiratory drive. Okay? Change in clinical status of the patient is the primary reason why patients poorly interact with the ventilator. So, them starting to change for the worse is a clear indication that they're not in sync with the ventilator. Okay, you might have some excessive secretions, bronchospasms, and agitation. And just remember too, these are, besides agitation, excessive secretions and bronchospasms deal with upper airways. Okay, so when you have upper airways, the airway resistance increases. All right, then you might have a possibility of auto-peeping. That's why when we suction the patient, we do what we call secretion management. We can minimize our auto-peep. All right. So remember the conditions, and I'm not sure if this was in the last slide or last lecture. Remember the conditions of auto-peep. That is increased airway resistance and an increase in static compliance. What do I mean by that? Increased airway resistance. I have a lot of secretions. I have bronchospasms. So therefore, I'm having a turbulent flow. Okay, there's a lot of turbulent flow because of secretions. Air is not flowing out in a laminar type of flow. So I have turbulent flow in the upper airways, and now I have an increase in static compliance, meaning to say my lungs are better. My lungs can expand even more. So I have all this. I breathe in. I got all this air. I try to ventilate. I can't because I have a lot of secretions. All right, so I try to breathe in. I might not be getting enough oxygen because of the turbulent flow due to secretions or bronchospasms. And so therefore, when I try to breathe out, I can't breathe out all the air because of the secretions or the bronchospasms. So therefore, that will lead to auto-peep. Okay, so we want to get rid of the secretions. We want to minimize the bronchospasms in the upper airways, so the upper airways are clear, so that even if I have a increase in static compliance, meaning to say my lungs are getting better and they can extend and stretch more, and I can take in more volume, I can blow out more volume. So therefore, I will be able to ventilate out all that CO2. Okay, so clearing the upper airways, which involves secretion management, is going to help minimize your auto-peep. You have other things too. You have fever, hypoxemia, and hemodynamic compromise. So all of these will play a role in a clinical status change. Artificial airway problems is huge, and we'll talk about that next slide. Pneumothorax, pulmonary edema, embolism, dynamic hyperinflation, all of these things can also cause a change in clinical status. So we have artificial airways. We do have some poor interactions. Again, common causes would be a sudden respiratory distress. Patient will just start having tachypnea, tachycardia, possibly dyspnea, increased work of breathing, accessory muscle use, while on a ventilator. So you're sitting there like, what in the world is going on? You know, I thought I was in control, but since they're not in sync with the ventilator's not helping them, so therefore they're getting they're not meeting their ventilatory demands, and so therefore they are in respiratory distress. One of the concerns you have to think about, and this is where oral care comes into play, or any type of care. All right, because now you have a development of biofilm. Biofilm is like a small layer or a thin layer of bacteria around certain areas. This thing is a biofilm on the internal surface of our artificial airway, whether that be a endotracheal tube or that will be a tracheostomy tube. Whatever the case, we don't want that in there, because if I have biofilm around the internal surfaces, now guess what? I don't know if you guys remember, but that's how VAP starts, ventilator-acquired pneumonia. So I have this biofilm outside the tip of my endotracheal tube. Now let me ask you this. What is it that allows the patient to breathe with an endotracheal tube? Besides the fact that they're breathing through the tube, you also have the balloon. The balloon blocks everything else around the endotracheal tube so that airflow will just move through the tube, right? Now, let me ask you this. Do we fully inflate the cuff or the pilot balloon? No, we don't. Right? We have something called minimal occlusion volume or minimal leak technique. Now we have capillaries around the trachea. So if I inflate that pilot balloon fully, I'm going to occlude those capillaries and cause some necrosis in that area. And that's something we don't want to do. So I have biofilm. I have minimal leak technique, meaning to say I have a little bit of a small little opening around the balloon. And if this biofilm kind of starts leaking down past the balloon, going into the trachea, going down into the lungs, I may have some ventilator-acquired pneumonia, or I might just have some pneumonia. All right, ventilator-acquired pneumonia is actually determined on how long the patient has been on a mechanical ventilator in the hospital. So usually it's a certain amount of time. I can't remember. I think Pilbeams really describes it really well, but you may have VAP or you may have just pneumonia. But that's just the thing. We don't want that. We don't want that biofilm in there. So that's one of the concerns. Excessive lower airway secretion production can cause obstruction. That's correct, because if I have a lot of secretions down in the lungs and the alveoli, that's going to obstruct any airways from going in and coming out. And so therefore, if I have a large occlusion or a large obstruction of secretions and I can't ventilate thoroughly, guess what then? I'm going to have a lot of VQ mismatch, and then if a lot of the alveoli are blocked with secretions, I'm going to have severe shunting. Okay. Let's see. Results in an increase in peak airway pressure. Okay, so if I have an obstruction, I'm hardly getting any air, so my straw basically is narrowing. It's going to increase pressure. So your peak airways pressure, or your peak inspiratory pressure, it says results in an increase peak airway pressure during volume ventilation and a decrease in tidal volume and pressure ventilation. All right, so that's what the obstruction does. It's going to increase your peak airway pressure and volume control. All right, in pressure control, it decreases your tidal volume, because in pressure ventilation, we're just controlling pressure. So if I have a pressure of 20 and it gives me a tidal volume of 450, okay, pressure of 20, tidal volume 450, and I have some secretions that's causing an obstruction, that airway is not going to get into the lungs, and so therefore I will have a decrease in tidal volume. Okay, and then the same thing, increased peak airway pressure. Here I have a lot of secretions. I can't get them out. I'm narrowing my tubes, therefore it's going to take more pressure. If you can't visualize that, think about a hose, a garden hose. Okay, and you put your finger at half of the opening. What happens? The water starts squirting further, because by narrowing the garden hose diameter, you've increased pressure. Same thing here. The secretions are your thumb. The garden hose is your airway, and the water is your airflow. So think of it that way. So when your secretions block part of your airway, then your flow goes at a stronger pressure. So hopefully that helps you. Okay, all right. Endotracheal tube movement or kinking. If our AT tube moves or it's kinked, either a patient's biting it or for some strain, or most likely it's going to be kinked because the patient's biting it. So that's going to cause airway pressures and tidal volumes to decrease rapidly. Okay, and it says if we're talking about movement, we're talking about movement into the oropharynx or into the right main stem bronchus. Okay, remember that when I'm going into the main stem bronchus, I'm ventilating only one lung, and that's going to be less pressure. So imagine if you have the endotracheal tube and you're ventilating 500. That's for both lungs. Now if it moves further down, now I'm in the right main stem bronchus, but guess what? I'm ventilating at 500 mLs on one lung. That's going to mess them up really badly. Okay, and that's where you're going to have that asynchronous event, because Now you're going to have high pressures because one lung may not take 500 mLs. So you're over distending the alveoli. You're possibly causing some barotrauma, alveolar trauma, volutrauma, barotrauma. There's a whole lot of trauma going on. Okay, and that's what's going to mess up the patient. That's going to cause an ALI. ALI can possibly lead to ARDS. And now you got ARDS to deal with, on top of patient not responding because they are asynchronous to the ventilator. So you can start to see the buildup of issues if you are not cognizant of how the patient is breathing on the ventilator. Okay. Endotracheal tube placement for an adult male is approximately 23 centimeters at the teeth. All right, that's on the exam. Straight up. Just remember that. Okay. Cuff herniation, again, if you over distend the cuff, it's going to cause some occlusion, maybe some irritation, swelling, so therefore you're really going to have an area in the trachea that's going to be so swollen that might put pressure on the pilot balloon, causing the pilot balloon to break. And therefore, then you lose the pilot balloon and you'll have a leak. Okay. Development of tracheal stenosis, tracheomalacia, TEF, innominate artery rupture. So therefore, if I caused a lot of trauma to the trachea, that's going to get me some stenosis, some hardening. So remember, tracheas can expand. And also you got to remember what is behind the trachea. Why do we have cartilaginous rings on the trachea? And that's because we have the esophagus behind it. So if I have tracheal stenosis, therefore my trachea cannot move easily if I'm eating. So if I'm trying to eat something kind of big and my trachea can't move to allow the passage of the food from the esophagus to go down, that's going to cause some issues. That can cause some possible dysphagia. Okay? So again, think about all of this when you're thinking. When you're trying to study and learn about patient ventilator asynchrony, because there might be issues with the artificial airway. All right. So with the ventilator. This says infrequent cause of poor patient ventilator interaction is malfunction of the mechanical ventilator. It may not be the patient. It may not be your fault. It might just be the darn stinking ventilator. Our ventilator settings should be checked to ensure an appropriate tidal volume. So this is where your vent checks come in. You want to make sure everything is set to what the doctor has ordered. Okay. Also look at what the patient is doing spontaneously. Okay, you might have programmed a tidal volume of 500, they're getting 420. Is there a leak? Or is it just subtracting tubing compliance? Alright, so those are some things you might want to consider. If you suspect there's a problem with the ventilator, remove the patient from the ventilator and manually ventilate the patient with your bag mouth vest. There should be one at bedside at all times for ventilator patients. It may not just be that. It might just be one in every bedside. So if you think there's something going on, you're pushing buttons and nothing's responding, feel free to take off the vent circuit and start bagging the patient. Right. Make sure that they're coming back up in terms of their O2 sat. You can do that. Don't be afraid. If ventilator's not working or you feel that the patient's spiraling down, grab the ambu bag. Bag them. It won't hurt. You're just basically helping them out, because if it's a ventilator issue and you manually ventilate them, then you're bringing the body back to homeostasis. And from that point on, you can either swap out the ventilator and tag and bag that for your biomed to fix, or it might just be a setting that's off. It could possibly be tubing, something wrong with the tubing. So it could be your circuit. It could be, maybe your ballard. Maybe someone suctioned and then pulled back too much, and now you have this really inflated bag around the catheter. I like to call it the balloon slug. You have a big old balloon slug there, and with that balloon slug, that's going to cause a decrease in tidal volume. So you might have a low minute ventilation or low volume alarm appear, and then when you look at the patient, you'll see that the ballard balloon is going to be all inflated, and that's where your volume's going. Don't be afraid to disconnect and bag. Okay, and bagging, when you're under control of that, most likely that's going to help the patient drastically. Okay, especially in an emergency setting, don't be afraid to disconnect them and bag them. All right, so during controlled ventilation, the patient has absolutely no control over the process of ventilation. Now, sometimes we want that. Sometimes we want to rest the muscles. Sometimes we want them to relax so that they don't increase CO2. All right, so it's saying the ventilator moves gas into and out of the lungs based on how the clinician decides to set the mechanical ventilator. So depending what mode that we want, that's what we will program the ventilator. And it'll do what we program it to do. Okay. During assisted mechanical ventilation, such as Simv with pressure support, the patient and the ventilator must intimately interact, meaning to say that it definitely has to be on point. All right, we don't want, there shouldn't be any room for error. If there is a very slight error, that's not going to affect them physiologically. Ventilator is set to meet the neurological output from the respiratory center. There is no competition between the respiratory center and the ventilator. So what we try to do is we try to mimic the patient's breathing pattern and neurological output to stimulate, or should I say innervate, the diaphragm. So however long it takes, that's what we try to mimic. Now, most of the time, doctor will give us a cookie cutter vent setting. They'll say AC at 12, tidal volume 500. FiO2 would be, I think, 40%, and PIPA plus 5. That's most of the time. That's what I get. And then we do a blood gas after an hour, and then we adjust. That's what they do. Okay, and so we're not thinking about neurological output. We're not thinking about syncing with their normal breathing pattern. Okay, some people, they might breathe a little faster. That just might be how they are. That's just the body's way of compensating. COPDers, they like to breathe a lot slower because they like more CO2. So we just have to be cognizant of how the patient breathes and how their breathing patterns are. Again, this is rarely achieved in critically ill patients because they are critically ill. So it could be some impedance of the neurological outputs, and so that's just where we have to work with nursing to get them under control in terms of getting them back to normal physiological state, so therefore we can also get them back to their normal breathing pattern. The more variables controlled, the greater the likelihood of asynchrony. That is so true. The more variables controlled, the greater the likelihood of asynchrony. Because we control so much, the patient can't do things on their own. And if they want to breathe and we don't let them breathe, for example, I have them on AC, they want to breathe a lot more times, we may allow, the mode will allow them to breathe, but they're going to get 500 regardless. Now, that's the difference between SIMV and assist control, or CMV. In CMV or assist control, patient can trigger the breath, but they will always get the tidal volume that we entered. So if I put 550 and they triggered the breath, they're gonna get 550. No ifs, ands, or buts. Okay. So with SIMV, when I put the patient on SIMV, they can trigger the breath, but whatever they breathe, whatever tidal volume they draw, that is what they'll get. So if I have someone on SIMV and I put them on SIMV of 12, tidal volume at 500, so when they trigger the breath, they're not going to get 500. They're going to get whatever they get. So if they were able to breathe 420 that one breath, they get 420. If the next time they have a spontaneous breath, they get 500, they get 500. So that's going to be based on the patient. Now, that is where we allow them to take over, and their neurological outputs are on point. So SIMV would be a good mode for them to start breathing on their own, to start increasing their muscle activity, because most likely if the nurses were able to kill off the bacteria, let's say that was causing pneumonia, and now their static compliance starts to increase, airway resistance starts to decrease because we pretty much killed the bacteria. So we're clearing out the airway, patient's feeling better. Then at least then we can start putting them on SIMV and start weaning them off, increasing their muscle strength, increasing their neurological outputs, strengthening the diaphragm to increase muscle mass. Because usually if you're on sedation or you're not using your muscles, right, you're on AC. Remember, none of the machine's breathing for you, so you have a decrease in neurological output. Your brain is saying, "Hey, I'm breathing, but I'm not sending the signal to breathe." Oh, okay. I guess we're just gonna chill. And then your diaphragm saying, "Hey, I didn't get a message, but we're getting air." Okay, we're just gonna sit here and chill. So that's where that muscle atrophy can come into play because they're not doing anything. So now with SIMV, you're really making it work. So instead of them hanging out, on the couch all day, what SIMV is doing is getting them back into shape. Okay, so that's, now when I say get back into shape, I'm talking neurologically and I'm talking muscularly in terms of the diaphragm. Okay. Volume ventilation is the most controlling mode of ventilation because we control volume, flow, and time. Okay, and then in that sense, the patient will control pressure, or meaning to say that the pressure varies. The likelihood of asynchrony is greater with ACVC or volume AC than any other mode of ventilation. You will see, based on the different asynchronies, that AC and volume control has the most. Okay. Now, if you're on AC pressure control, that just means that the ventilator controls only pressure and time. Time meaning your eye time. Okay. Less control, less likelihood of asynchrony. So it doesn't control as much. So therefore, pressure AC, you will get less asynchrony. But because doctors are so comfortable with volume AC, you will have a lot of asynchrony. So if we're dealing with pressure support, only the pressure is controlled. Okay, now, I know some of you guys get confused between pressure support and pressure control. Okay, pressure control is when we control the pressure. We set the pressure and the volume varies. Okay, so we use pressure control as a lung protective strategy. You heard me say that time and time again. It's a lung protective strategy so that we don't pop the lung. Okay, so if our static compliance is decreasing, meaning to say that the lungs are getting stiff because of an acute lung injury or ARDS, we want them on pressure control. Okay. Now, pressure support, on the other hand, is more of, I would probably say, more of a supplemental type of ventilation where it only happens on inspiration. Okay, with pressure control, inspiration and expiration, those pressures are controlled. All right. But on pressure support, it only helps the patient on the inspiratory phase of a breath. Okay? Because it has to, the pressure support kicks in so that the volumes can match most likely what we've programmed it. So if I'm Simv and I'm pulling 150, I have a pressure support of 10 centimeters of water pressure. When I breathe my 150, the pressure support's going to kick in. And so it's going to give me an extra plus 10, which will probably push my volumes most likely maybe in the 400s. So that's going to help me get more volume into my lungs so I can breathe it out. Okay? And so therefore that's going to help my minute ventilation. That's going to help myself ventilate. Okay? All right. Then you have these two things. You have a proportional assist ventilation and a neurally adjusted ventilatory assist, PAV and NAVA. Now, I haven't really dealt with any of these, and I'm not sure if they're in an actual ventilation, but it says least likely to cause asynchrony because they do not exert any control over the patient. Okay, and it also says it does not control pressure, flow, volume, or time. What they do is provide a proportional assist based on patient demand. Now, I can't remember off the top of my head, because this is all lecture. I'm not looking at any reference material. I know that NAVA is dealing with the neurological impulses that are firing from the central nervous system to the diaphragm. So based on that is, I think, they deal with their neurological aspect, and in the proportional assist ventilation, I think that's dealing with diaphragm. I'm not too sure. That's for some of you guys to study up on, because you should be reading. Anyway, you're not controlling any of these things, so therefore you are not going to have any type of asynchrony with this type of these ventilation and ventilatory assist. Okay, so PAV and NAVA. So depending on the patient, I mean, if the patient effort increases, ventilatory support increase, and vice versa. So these are great in terms of having the patient breathe on their own, and we have less interference and therefore less control, which leads to a decrease in the asynchrony. Ventilator can control one or more of the following gas delivery variables, and we know that already: pressure, flow, volume, or time. If I want assist control, volume control, so I'm going to adjust volume and flow. If I want pressure control, assist control, or pressure control CMV, I'm going to control pressure and time. The more of these variables controlled by the ventilator, the greater likelihood. So we've seen it said the other way. Actually, it's the same. It's the same way. We've seen that verbalized earlier in the slides. So again, so we don't want to control so many variables, because if we do that, it's going to cause it gives a greater chance to cause a ventilator asynchrony. Now let's talk about the different types. We have flow, and I drew you guys the flow time scaler and how it looks like on a graph. But normally what happens is that the flow that we set is not meeting the patient's demand. So when you saw the graphic on a flow asynchrony, you'll see it more of a concave rather than a convex, and that's just showing that it's taking the flow is being delivered too slow, to the point that if you look at the pressure time scaler and you look at the volume time scaler, both of those are going to show the slopes are more are leaning more. Instead of coming almost upright, they're going to be leaning more towards the right, because it takes a longer time for the lungs to inflate. Okay. So again, flow asynchrony can happen in any mode. The most common is volume ventilation, particularly CMV or AC, because we control flow. So all you got to do to fix this is just increase the flow. Okay, most common in again, volume AC, because a precise flow pattern and peak flow is set, resulting in the selected tidal volume being delivered in a precise inspiratory time. Okay, we know that. Most adult patients with moderate to strong ventilatory demands require a peak flow of 60 liters or greater. Remember, if I'm converting 60 liters per minute into liters per second, that's 1 liter per second. That's pretty fast. Okay, so it says along with the peak flow that increased to 60 liters per minute, changing to a decelerating flow pattern. So I don't know if you remember the decelerating flow pattern. That's when we have a very abrupt increase, and then it starts decreasing over time. Okay, so it's almost like the right angle, but the hypotenuse is sloping to the right, if you remember your geometry. Okay, and matching the I time to the patient's I time can correct flow asynchrony. So basically, increasing your flow, changing your flow pattern to a decelerating flow, and matching the I time to the patient's I time. So those three things will correct flow asynchrony on volume ventilation. Now, on pressure ventilation, it says is less likely to happen because you're not really setting flow on pressure, but you are setting I time. So it says inspiratory pressure rise time or pressure slope control adjusts the rate at which flow increases from baseline to peak. So we want to make sure that the rise time is dealing with your flow pattern. Okay, so we want to make sure that or the slope control adjusts the rate at which the flow increases. So again, most likely it's going to be your I time. Remember, in pressure ventilation, we set I time. We want to make sure the I time matches the patient's I time. Okay, and so sometimes, I mean, you can look at the different flow patterns, but in pressure control, just set the I time to as close to the patient's as possible, and that should fix it. So again, it says for flow asynchrony can be greatly improved in volume ventilation by increasing peak flow and decreasing inspiratory time. We've known that already. If there's issues with flow, increase the flow. Okay, and when you increase the flow, you decrease the I time. In pressure ventilation flow asynchrony, it can be corrected by adjusting the rise time. And so the thing is that with pressure ventilation, we control I time, so we can fix I time. All right, so that's how we deal with flow. It's about the I time. We shorten the I time. That's going to get the flow in faster. Okay. Trigger asynchrony. So remember, triggering the ventilator to initiate the breath. Okay. So the most important variable affecting trigger asynchrony is the presence of Auto-Peep. So we did talk about Auto-Peep forming based on an increased airway resistance, so a lot of secretions, and some bronchospasms, and possibly patient biting or kinking the tube, and a increase in lung compliance, meaning to say I can accept large volumes of air in my lungs. Okay, so large volumes, very narrow passageways with turbulent flow will cause our Auto-Peep. Okay, and when I have a lot of Auto-Peep, it's going to affect the patient triggering the machine to give a breath. So that's where our trigger asynchrony comes in. So we have a trigger delay And that could be, again, caused by Auto-Peep. Poor sensitivity setting. You put that sensitivity too high, it might even just miss. And then your patient's trying to trigger the machine won't kick in. Hey, or it's just the ventilator's just all messed up. All right, length of time between the beginning of a neuro inspiration and activation of ventilator is excessive. All right, so when they're talking about neuro inspiration, they're talking about the electrical impulses triggering inspiration. So if that is delayed, then it'll show that the patient triggered the breath. But then if my ventilator is also on a time trigger based on respiratory rate, it may not trigger when the patient wants it to trigger. Should not exceed 100 milliseconds to avoid patient perception of the delay and an increase in ventilatory drive. So this, the length of time between the neuro inspiration and activation of the ventilator, it should not exceed 100 milliseconds. That's pretty small. You have seconds and you have milliseconds. So, that right there, it's really, really short time. Mistriggering. Sometimes the machine just doesn't deliver the breath. It says patient is unable to trigger the ventilator with each inspiratory effort. In the presence of dynamic airways obstruction, the application of PEEP offsets the effect of Auto-Peep on missed triggering. So let's think about this. Missed triggering. Okay, the ventilator is not triggered regardless that the patient triggered it, right? Either it be a flow trigger, it be a time trigger, it be a pressure trigger. Patient did his job, but the ventilator missed delivering the breath. Okay, so now you have this prolonged gap of no ventilation or oxygenation. Okay, and so therefore you will have a low VQ, correct? Because you have hardly any blood flow, hardly any air being delivered. And then on top of that, you have your circulation at the alveoli level. So you're going to have low VQ. Okay, when you have a low VQ, you're going to have less air exchange. So therefore, you're not going to get any oxygen, and you're going to have an increase in carbon dioxide. Okay, so if I continually have mistriggering that prevents me from getting a breath, therefore I'm not going to have any gas exchange. Therefore, I'm going to have low O2 and a high CO2. So I'm going to have a ventilation and oxygenation issue. So that's the big thing about this. Okay. And now it's saying in the presence of dynamic airways obstruction, the application of PEEP offsets. All right. So if I have so when we talk about dynamic airways, we're talking about the breath or air that's constantly moving versus static. If I have a static airway, I have no air movement, but there's a pressure. All right, that's where your plateau pressure comes in. So plateau pressure is dealing with pressure that is in a static state of air movement, meaning to say that there is no air movement. And so if there's no air movement, there's only what's left is there's a certain pressure in the airways. That's where your plateau pressure comes from. And the plateau pressure deals with your static compliance. Now think about dynamic compliance. Think about dynamic airways. When you think about dynamic compliance, you're dealing with the peak inspiratory pressure and the PEEP. Okay, the baseline. So when we talk about peak inspiratory pressure, you're talking about upper airways. When you're talking about PEEP, you're talking about pressure in the alveoli. So that whole range from the upper airways all the way down to your alveoli, that is your dynamic compliance, how well the air is moving. So if there is some things that obstruct dynamic airways or dynamic air movement, if I have any type of obstruction, guess what? I'm going to have some Auto-Peep. So in this particular setting, when you have a presence of dynamic airways obstruction, okay, you would, so if I have an Auto-Peep of 7, I have to put my PEEP at 7 to offset it. Okay, now this is dealing with dynamic airways obstruction on a missed trigger. Don't think that this is, if I increase the PEEP to match Auto-Peep in any circumstance, it will negate the effect of the Auto-Peep. No, that is incorrect. You have to remember this is dealing with dynamic airways obstruction on missed triggering only. Okay, I'm going to say that again. This is dealing with dynamic airways obstruction on missed triggering only. I want you to understand that, because I don't want you to sit there like, well, if they have patients have increased work of breathing, can I just match the PEEP with the Auto-Peep? No. Remember, we talked about this. To correct Auto-Peep and an increased work of breathing, we set the trigger 1 centimeter water pressure. Let me think. Is that what we're dealing with? Yeah. So it's pressure. So 1 centimeter water pressure below the Auto-Peep to decrease work of breathing. That's where that comes from. But this, using PEEP to offset Auto-Peep, that's only in a mistriggering and you have dynamic airway obstruction. Okay. I want to stress that because I don't want you to take that concept and start blowing it up to everything. Okay. All right, double triggering. What's happening here? I trigger the ventilator to give me breaths. So I'm breath stacking. Now, you guys, I'm not sure if you guys tried breath stacking. It's a horrible sensation. I've tried it. It's, and I'll probably make you guys do it in class so you guys understand what double triggering is. But most of the time, this is how our COPDers breathe. They might be used to it, but for us people that are not COPDers, double triggering is very, very uncomfortable. Normally, it's a result of the patient's ventilatory center wanting a larger breath or a longer inspiratory time, meaning to say our I time is too short than is set on the ventilator. So, patient sends a signal to the diaphragm. Diaphragm drops, increases our tidal volume, but the brain says, I don't like that. I want another one. All right, so instead of going through your normal total cycle time, your brain gets a little greedy, and it wants another breath, but it wants it at a larger, wants a larger breath, or it wants to have a longer inspiratory time, meaning to say that the I time is just too short. Now, that's kind of strange for the brain to think, but sometimes the brain wants what it wants, and if it wants a shorter or longer I time, and if this is what the brain wants, and it's saying, hey, I need a longer I time to help the patient breathe a little better, I might just have to give it to them. Okay, it's most common again on volume AC, because it is most likely it probably was a pressure trigger. That's what it seems like to me. Or it could just be volume. I'm sorry, or a type of pressure trigger. I'm not too sure, but it's just because the brain just wants another breath. Okay, auto triggering. For some strange reason, the machine triggers a breath when the patient is not wanting it, and that breath is outside of its total cycle time. Okay, so let's say total cycle time is 6 seconds. It'll auto trigger maybe in 5. So now you have that 1 extra second that was supposed to be expiratory time that goes towards your inspiratory time. Okay, seemingly automatic triggering of the ventilator without any patient inspiratory effort. So now don't get this confused with a mandatory breath. Okay, mandatory breath, it's given to the patient without any patient inspiratory effort. All right? It's mandatory breath. It's triggered by the machine. But don't think that that is a form of auto-triggering. Auto-triggering is when it just triggers. Okay? It just happens. It gives a breath regardless of if the patient triggered the breath or it was triggered by time. So it just delivered a breath. Okay, that might be where you might have issues with your ventilator when you have some auto triggering. Reverse triggering. It's basically a controlled mechanical breath results in simulation of the respiratory care triggering the subsequent breath. This form of asynchrony occurs only during controlled ventilation. All right, so what's happening here is patient is getting a breath from the ventilator, and for some reason, I'm sorry, here we go. So patient breathes. That breath triggers the brain to send a signal to breathe again. Let me hold on a second. Let me double check this real quick here. Okay, so here's what's happening. All right, based on the definition here, it's saying the patient triggered the breath because it's saying simulation of the respiratory center. So patient's triggering the breath. For some strange reason, that breath caused the ventilator to give a breath. It's strange. So the patient's breath triggered the machine to give a breath. Okay, so that's what the slide is telling us. And it says this form of asynchrony occurs only during controlled ventilation. Now, to me, controlled ventilation would just be more of invasive mechanical, or it could be non-invasive, because we are controlling ventilation. All right. Okay. Cycle asynchrony. Cycle meaning ending of inspiratory phase. Okay. So a cycle asynchrony occurs when the ventilator ends the breath at a time different from when the patient's respiratory center wants to end the breath. So it might end the breath before or after. Okay. More common in pressure targeted ventilation than volume, but it can occur in all modes. Okay. So most common in the pressure targeted or pressure control. Okay. So there's two forms of cycle asynchrony. Asynchrony that results in an inappropriately long inspiratory time, all right, and also asynchrony that results in an inappropriately short inspiratory time. So apparently we got to get this right. We got to get the inspiratory time correct, because if we do it too long or too short, you cause a cycle asynchrony. Okay. So to fix this is just adjusting our inspiratory time. Okay. As long as we set the inspiratory time, we're great. And again, it's most common in pressure control because we control the I time. So this should be pretty easy to fix. You just adjust your I time just to make sure that it fits with the patients. And then there you go. Okay. Mode asynchrony. So the selection of a mode of ventilation that is highly unlikely to meet a patient's inspiratory demand. Okay, most likely with volume AC followed by pressure AC and then pressure support. Okay, so volume AC, if you have them on volume AC, it could be a mode asynchrony followed by pressure. So here's the thing. Here's what's going to happen. And I kind of said this before. You have a patient on AC. They're breathing more than the respiratory rate that you set on the machine. So I set it at 12. They're breathing 24. Okay, and that might cause them to breathe faster. Right, so they're beyond. They're beyond our normal range, which is 12 to 20. They're at breathing 24, 26. Okay, so now the body is telling the patient, hey, we need to, in a sense, it seems like they want to blow off more CO2, right? Because they are breathing at a faster rate. And that might just be also a compensatory mechanism because we're not meeting their demands. So that's why I said switch them to SIMV. So if they are on AC volume control, and they're doing that, you switch them to SIMV. Guess what? Most likely the respiratory rate goes down, and they start breathing slower and normally, a decreased work of breathing. Okay, so my mode, my AC/VC, was causing the asynchrony because the patient wanted to breathe on their own. They were stronger in terms of their diaphragm. The neurological signals were going really well. The muscles were much stronger. The innervation of the muscles were contracting really well. So if I kept them on AC/VC, that would cause some patient asynchrony. So switching them to SIMV would be the better choice for them so that they can breathe on their own. They're not getting forced volumes. They're getting volumes that the muscles are breathing, and that's going to increase the neurological innervations. It's going to increase the muscle strength, and therefore overall it's going to help the patient strengthen their respiratory muscles to the point of extubation. Okay, least likely to occur with our proportional assist ventilation as well as your neurological ventilatory assist. All right. So to recap, the four variables that can be controlled during classic modes of mechanical ventilation are pressure, flow, volume, and time. The general types of asynchrony are flow asynchrony, trigger asynchrony, cycle asynchrony, and mode asynchrony. So again, to fix it, flow asynchrony, increase the flow. Trigger, we're going to deal with I time. I'm sorry. For trigger, we're going to deal with I think with trigger we're dealing with pressure in terms of sensitivity. Okay, we want to make sure it's sensitive. So if the patient doesn't have an increased work of breathing, meaning to say we set our trigger or our sensitivity one below their baseline, whether it be their PEEP as their baseline or Auto-Peep as their baseline, we want to get that sensitivity, pressure, or flow, depending on what you set. We want that to be close, or maybe like 1 or 2 below their baseline. So that would help trigger the ventilator. Okay, again, sometimes it's the ventilator, and so therefore we have to continuously make sure that the ventilators are getting their periodic maintenance. And when you guys move on in the field to become directors, hey, that's what you'll deal with. You'll deal with what we call PMs, or periodic maintenance. You want to maintain those ventilators. They're getting cleaned up. They're getting their diagnostics checked. Then that goes beyond your EST and SST. So they're getting a good, thorough check and analysis of the circuitry and all that stuff, which your biomed department will probably do. And so by taking care and maintaining the ventilators, as well as making sure that the patients, they have good flow, that they have good sensitivity. For cycle asynchrony, you want to make sure that the eye time is mimicking the patient's eye time. And also mode is definitely going to be based on your assessment skills. So you want to make sure that the mode that they're in is correct. If, for example, I have a patient on volume control and they have ARDS, my peak and my plateau pressure are going to rise. If I'm one of those therapists that just does vent checks, and I'm one of those therapists that I start hiking up the alarms so the alarms don't ring as much, and I'm already hitting a pressure of 50, 55, and I increase my alarm to 60 so that it doesn't alarm, and it's quiet, but all the while the patient's lungs are getting stiff or having lower compliance. If I'm going to be that type of therapist, that's going to mess up the patient, and that would be another example of a mode asynchrony. Because when I have someone on ARDS, their pressures are going to be higher than our cutoff, which is 30. If they're in the 50s, 60s, I'm going to cause a pneumo. So I will switch them to pressure control, so I can control the pressure, and therefore they're going to be much more comfortable. Now, the problem is where you will have to fix their tidal volume, all right, and overall their minute ventilation. But I made them comfortable because I didn't over-distend their alveoli. I didn't over-distend their lungs. And now they are somewhat comfortable, but now I just have to work on getting their tidal volume and minute ventilation up there. Okay. All right. So PAV and NAVA cause the least asynchrony because they do not force a ventilatory pattern, but follow the ventilatory pattern selected by the patient. Now, again, I am not sure about PAV and NAVA. There are different types of, I don't know if there are different types of ventilator. But I've never seen them. If they are a ventilator, I've never seen them. I know they're a type of ventilation, but they deal more for, I wonder if you probably have to be doing more invasive stuff with that, because it does take on neurological, the NAVA deals with neurological issues, and the proportional assist, I think it deals with the diaphragm. So those are, because you don't see those as modes on a ventilator, and they're saying it's a type of ventilation, and so I think those are mostly for neurological patients and possibly in ICU, CCU. You might see something like that. I'm not sure, because for some reason I can't remember what Egan says. So read up on that, particularly the PAV and NAVA, because for some reason I'm just drawing a blank. That might just be because I'm heavily medicated and I'm pretty congested. All right. So anyway, hopefully this helps. Again, you will have 22 questions based on all of this stuff. And again, the stuff in red are on the exam. All right. So study up on what's in red. Try to formulate your concepts. I tried taking you through various instances where You need to utilize critical thinking. And some of this are just straightforward like this. This is going to be a straightforward. How long? This is if a patient has a high ventilatory demand, what would be the inspiratory time? So you would just memorize 0.6 to 0.9 seconds. All right, so some of it's memorization and recall. Some of it is the multiples. So there should be no surprise. Probably the only surprise you'll get is probably the extra 28 questions I will add. That will probably be more of a case study / cleanse sim. And it's just really taking your knowledge to the next level. But just want to make sure that you guys are understanding the material. All right, guys, that's it. That'll do it for chapter 47. That'll do it for me. Stick a fork in me. I am done. So, guys, hopefully this helps. And I know that I didn't have a chance to lecture, but hopefully that this helps you to the point where like you can just fast forward, you can rewind. And again, I'm not going to do this for every chapter. It's just chapters that I don't have time to lecture on. All right. Okay, guys. Thank you so much. Enjoy the rest of your week. Enjoy your clinical rotations. And I will see you guys on Monday. Take care.